I would, this burr, I'm going to go a few millimeters, probably 4 to 5, beyond the apex, to be able to determine at least if I can get this drill going. All right, now you'll notice when I stick this in here, I'm already to 15, almost to the crest of the gingiva. I'm almost to the limit of that burr. You obviously know that if I tried to use this burr directly onto the drill head, it wouldn't fit. Now I asked my trustworthy and appropriate and very experienced prosthodontist, Dr. Larson, Bill, does this angle look okay to you? Is this is where I would likely want to start? Okay, so then I'm going to go ahead and make about 5 millimeters worth of hole, and I don't have anything to stop with. Now, obviously, I'd be doing this under irrigation, and again, you have to be careful not to push too far. But now what I've done is just created an osteotomy at the apex, and I don't really care if I go a little too far on this because this is not going to determine my final position, as long as I don't go into the piriform aperture. Now you see a little bit of vibratory movement with the extender, but not bad. And this drill does not lock into the extender. So now if you look up the socket, you can see that I've made a hole there, and it's slightly to the labial aspect. And I'm going to enlarge that hole. Thank you, Bill. Thank you. You can see where my hole is and my angle. Now, do I need to use a burr? If I needed to redirect this in some way, shape, or form, I could try to use the side of the burr to redirect it from a position perspective. But I think my angle is pretty good, and that's normally the case. I'm usually not putting in. So can we move to the next size? We're going to, we've determined on the, let me have the, I'm sorry. Go ahead and change that out, please. And then I'd like to have a perio probe if we have one. Because now I'm going to measure my mesial distal socket dimension. Yeah, I can use that. That's an implant. Oh, I didn't do that. Well, actually, that doesn't have a measuring stick. I mean, I can use this little device to see where my position is, but I need a perio probe to be able to measure my medial distal dimension of this socket site to make a determination as to what size of implant I can use. And as Paul and Bill would like, they'd like to have me use, if I can use a 4.7, I should use a 4.7. And I think I can use that on this particular case, but I don't think I can use a 6.0 because I wouldn't have enough dimension between the teeth. In fact, I don't know if I've ever used a 6.0 in a simple incisor site. Okay, so now here's my next drill. You can I know I'm not showing you this from a labial perspective, but I can see my mark. My 15 mark is about 4 millimeters superior to the crest of the alveolus. If I retract this with my fingers, you can see that I can see my 13 millimeter mark at the crest as well. And that helps if you've made this flap ahead of time, because they're going to want to see typically where that alveolar bone is and where the adjacent CEJ is for final position. So I'm going to go ahead and I'm only going to be prepping about 5 to 6 millimeters of this hole. Okay, so there's I'm drilling deeper, deeper, deeper. You can see how deep that's going in there. I'm about 2 millimeters subcrestal with the longest dimensional mark on my device. So I'm going to stop there. You can see the hole's gotten bigger. Okay, let's go next size. Now you can see that's just progressively getting bigger at the apex, but it's slightly jacked to the labial bone.
And again, if you were doing extraction drilling, you would have your dental assistant keep the drill bone particles, bring them out of the loop of the drill, put them in your damper dish, because as long as you have them, you might as well pack them back into that socket.
And I like to go up the drilling sequence, even if it's not hard bone, I typically use every drilling sequence, because I think that's kinder and it's easier to make it work. Okay, so this is, now it's pretty much self-directing, yeah, and so my angle's still okay? How about my depth? Again, I want to go too deep rather than not deep enough. Because if I haven't drilled deep enough and he tells me to go deeper, I can't. Okay, let's go next one. Thank you. And I'm just retracting this with my finger just so you can see where that crestal component is. I typically wouldn't do that. But you always have to have an idea of where your stop mark is.
What size are we going to use? What size?
We're going to do 4.7.
Okay, what size is this?
4.7.
This is our last drill in the sequence, so you can see how big that is. Is my angle okay, Bill? Okay. And that just kind of goes up the hole, okay? Is that deep enough? Okay. Alright, so you gotta use the extender on this. Okay, now we're gonna go ahead and use a 4.7 by 16 millimeter implant. So he's going to get out the implant. It's just like yesterday. We'll loosen the mounting fixture a little bit with an extra inch, just to make it, and then tighten it back up again, and then we'll mount what you do. Pardon me? Yes, it is. It's very important today. More important than it was yesterday. Okay, now you're going to need this longer insertion device. I'm sorry, that's for your drill mount. You need the longest one you got.
Is this the fellow right there?
Is that the longest one? Okay, so then we'll take our implant. Okay, there's my implant. See how long it is. We go and put it into sight and up to the position. You can see how deep it goes without me even doing anything. There's the margin. And it's turning, but it's going to be into that point. Now you tell me when it's deep enough. It's actually torquing to where it needs to be. Now, does that look, that looks a little linear to me. Yeah, and so, I don't know if this, I don't think so. Okay, let's reverse it and see. So it's gone lingual a little bit. It's not good. Okay, I'm going to keep it local. See, I can adjust that a little bit for him. Okay. All right, so he likes that position. You can see it's out the incisal edge. Now let's go ahead and take off the mounting fixture. So we'll take that off again, put something in the mouth so you don't lose this, and get a feel for when this turns out, the screw will click when the thread is out of the mounting abutment. So you can feel it click on every revolution, then you know it's free, and that's come off. Now, we look up the hole, and you can see where the implant is positioned from a labial-lingual perspective. When we look at it from the labial aspect, it's at least 2 millimeters below our crest. I think I would offer that it might be even more than that. Closer to 1, 2, 3, 3.5. And so Bill's telling me this might be too far subgingival. So if he thought it was, then we can back it out a little bit, provided it still has stability. So if you can give me that long screwdriver with that other straight device. Next one. We're going to unscrew this. We're going to take it back out a little bit because we're it's loosened up a little bit. So I might say at this point, Bill, I think that's kind of loose. I'd rather cover this up or put a healing oven on it as opposed to doing an immediate load. So Bill says fine. So he's going to put the cover screw. Now, if you're going to pack something in there toward the apical component or toward the coronal component, don't put the cover screw on first. If you're going to put the implant in with the material in the socket first, then go ahead and do that. But keep it clear for the cover screw here. I agree. What? I'm sorry. Oh, the Puros. Okay, so the cover screw is on, position is reasonable. I know what they're saying. So in this case, yeah, I said it will be. But if I take it much further, I mean, will it be a stability issue? Okay? So, my prosthetists are telling me it might be a little deep. And then maybe, and if they said back it out some more, I can do that. Because I think it'll still have stability, but it also, the more I back it out, the more limited its stability. Okay? Thank you.
The placement of immediate implants after the extraction for centrals and canines, that's not an easy one to do, because if they're a wide root, you're going to wind up having to place it too deep. So you're better off just preserving the socket and coming back and placing the implant at a later date. Laterals are a lot easier because it's a narrow root.
So if we got to this point and you thought it was too deep, and I said it's not going to be stable, I would back it out anymore. You got two choices. You can cover it up, put bone graft on the top and cover it up, or you can take it out, preserve the socket, and you blow the implant because you can't reuse it. Those are your options. But I certainly wouldn't, I would ask you not to load it because I don't think it'll tolerate any type of load, even temporarily. Okay. Now, as far as the lateral is concerned, I need some Puros, some hydration material, packer, and some suture, and a membrane. So if you want to hydrate, there's a little bit of some water. So as far as doing your socket preservation, if you want to load your bone graft into a syringe, you can. Some people use it just out of the. I typically just load it up on a periosteal elevator and move it into the socket. There are instruments we can use to pack it. Well, I don't think, do we? I could use a Woodson. The Woodson is silver. Okay, so if you want to load some bone up on the, no, I really don't. I'd rather just load it on the bone. So you might need a little more water, or you can stir it up with the number 9. Dr. Larson's mixing up my bone graft, and again, you can. It's just enough to kind of get it to stick together. If you put too much water in the grafting material, you can just put a sponge on it and push water out of it. It'll dry up a little bit. So you have some variability. So he's taking some water out of the grafting material because we got a little bit too much in. So you just put a sponge in the corner. It will soak out. Some of the particles go in the sponge, but not many. Then I'd like to have you give me a spoonful of number 9 periosteal.
Question.
Yeah.
So normally I was taught to harvest team and put it in.
I'm sorry, I didn't hear your question.
I was taught to harvest team to mix with the grass.
Oh, I don't know what the company recommendation is, but I never do that. But I don't know what kind of value it has. So we're just going to put some up the socket and we'll put it in this way. So Bill's got it here. It has some, it'll stick together to some degree as we push it up the socket, even with this Woodson. Although there are devices that help you, some people use amalgam pluggers. There are devices to help you get it into the socket. And again, sometimes some of these particles drop in the patient's mouth, so having a sponge in there is a reasonable thing. And again, it's just a matter of preserving the socket itself. You've got to leave yourself a little space towards the apical component of it. If you wanted to use a syringe, you can force it in with a syringe. There is a syringe in your set if you want to use it. It's just like loading an amalgam bacteria. Looks comfortable. Again, you can overstuff it and then come back. And you're very good at that.